Well, good morning, everyone. I'm Dr. Laura Lacher, and welcome to today's Medical Grand Rounds. We'll go ahead and get started with some logistics and then introductions of today's speakers. Please be sure to join us next week. We'll be hearing the talk From Guidelines to Justice, Hypertension Reimagined, given by Dr. Shelley Sanders. I'm here at Providence St. Vincent Southern Auditorium. Grand Rounds is a joint collaboration between Providence St. Vincent and Providence Portland Medical Centers. We are usually here live in the room at St. Vincent Tuesday mornings at 8 a.m. And our speaker is sometimes available live, typically at noon on Tuesdays at Providence Portland. You can join us in person. You can always join us on Teams Live to watch virtually. And you can earn CME credit by being in the room, joining virtually, or by watching a recording of the event. And that recording is available at the Grand Rounds invite link. You can also always know where and when we'll be meeting by that weekly invite. I'll be monitoring the Q&A throughout today's session. So for those of you joining us online, please go ahead and post any comments or questions. And I'll mostly hold those until the end as time permits. And now I'm particularly delighted to introduce not one, but three talented clinicians and speakers this morning. We are joined by Dr. Tricia James, an internal medicine physician and faculty member at Providence Portland Medical Center, as well as Director of Clinician Experience. Dr. James has been leading organizational well-being change at Providence for over 15 years with multiple publications, national presentations, and success stories. And she's deeply driven to help empower individuals and teams to recognize their power to create a better future. Dr. Alice Nyack is a dedicated primary care physician for the last 19 years and loves working with patients. She's currently serving as Associate Director for the Clinician Experience team, as well as a physician coach for informatics, helping clinicians improve their efficiency and work-life integration. She strongly believes that to be effective clinicians, we need to reduce burnout and support our community. And finally, we're joined by Karina Squire, who holds a Doctor of Nursing practice and also works in primary care. Prior to becoming a nurse practitioner, she worked as a cardiac lung transplant ICU nurse. Dr. Squire has been involved in well-being work for the past 7 years and is currently serving as Associate Director of Clinician Experience alongside Tricia and Alice. In 2025, Providence started an advanced practice provider board, which she currently chairs. Thank you so much for joining us, all three of you.
All right, good morning, everybody. Very happy to be here. So we do not have any financial disclosures, but we thought we'd start with a vulnerability disclosure, which is that our team has experienced quite a bit of stress and anxiety in putting this presentation together for you today. And we are inviting awareness and conversation around some challenging topics that we often see our community avoiding because they're uncomfortable. So while we feel strongly that it is important that we engage around the challenges to move forward, we also want to acknowledge that we don't have all the answers. All right, so a brief overview of where we're going to go today. The first is we're going to briefly review the impact of the clinician experience on individuals, patients, and organizational outcomes. We're then going to spend most of our time focusing on 3 current dynamics that are impacting the patient experience, really with the intent of naming some of the needs that we see and inviting some perspective taking. And finally, we'll wrap up by identifying possibilities to address those needs and share opportunities for co-creation, where we go from here. All right, so I'm guessing everybody in this room and online has a reaction to the word wellness, well-being, burnout, and it's probably going to be a wide range of reactions. I'm guessing many of them are going to be negative. And that is for good reason, I think, in that when this movement really was created, a lot of the discussion was naming or looking at what are the individual variables that are driving this experience. So I'm going to challenge that a little bit, but to look at what's the scope that we're talking about This is a messy graph. I don't want you to take in any of the specifics, but this is from wrap-up data from one of our big initiatives from 2024. And you can see this is across 21 different groups of burnout rates. Overall, the rate dropped from 51 to 46% for those that were participating in our intervention. But you can also see tremendous group variability. So each group really is its own unique phenomenon in terms of what's happening with their well-being. If you look at what has happened nationally, you can see the top line there is physicians, the blue line on the bottom is the general population. We saw a big spike in the national burnout rate in 2021 of 63%. The last time that this group kind of did their official survey, the national rate had dropped to 45%, which is still almost 1 in 2. And just to give voice to this idea of, well, what is creating this phenomenon? We now know and appreciate that roughly 80% of what is driving relative burnout or thriving is the workplace. Yes, there is this 20% that is individual factors and how we're all choosing to approach that workplace, but really what we're talking about is a workplace experience. So why do we care? This is a body of literature that's been growing rapidly over the last couple of decades and looking at what are the consequences of this burnout. Well, we know that individual clinicians suffer a lot when they are experiencing burnout. There's higher rates of disrupted personal relationships, substance misuse, PTSD, depression, and suicide. Our teams are struggling. So 26% of any individual's burnout is dependent on their team's well-being. We are seeing increased stress responses on our teams, less effective communication, and real erosion of trust in our community. Our patients are doing worse. So we know that burnout is associated with increased errors and increased patient safety incidents, reduced quality of care, and decreased patient satisfaction. Finally, this is also hurting our organization. Conservative estimates are that burnout is 2% of an annual budget for an organization. This is coming from things like turnover, early retirements, decreasing FTE, and if you're burned out, we also know that you're less productive. So for those of you that have been in medicine for a long time, remember that we used to have the triple aim, which was looking at improved patient care with lower costs and better outcomes. And in 2014, there was some acknowledgement that there was a piece of that puzzle that was missing in healthcare. And so it shifted to the quadruple aim with the acknowledgement that clinician well-being is an essential part of success in healthcare. I do want to bring light to this idea that we are existing in a culture in medicine where patients come first. This is a long-standing culture, and it's not necessarily a problem unless it's always true. So what I have seen play out over the years is that by always prioritizing the patient experience first and not paying attention to the clinician experience, it has started to have these detrimental effects. In reality, we know that both the clinician experience and the patient experience are integrally connected. We cannot take care of patients if we cannot take care of ourselves. So quick note about our department. And I want to give a quick shout out to Laura Chun, who's our amazing project manager, who's not with us in person today, but definitely with us in spirit. We were very intentional about the name of our department. We chose not to include the word wellness or well-being in our name. And that was to really identify and hone in on the fact that we are talking about the workplace experience for our clinicians. And we really through this transition, so our department was created in January of 2025. We're new. And this department was created with some key acknowledgements. First, clinicians are stakeholders in our organization. Second, workplace variables are the primary drivers of either thriving or burnout. Third, we each play a role in our local workplace experience and can affect grassroots change. And finally, partnership with leaders is essential for our success. I do want to name that our leadership in Oregon was a huge part of the fact that we are here today and that we have a Department of Clinician Experience. We are the only one in the system. Okay, so I'm going to transition into talking about these three big themes that we've identified as impacting the clinician experience. We know this is not a comprehensive list, and we decided to focus on these three things based off of what we see and hear in our community, and noticing that these are themes that are also very actively being called out and discussed at the national level. Before I jump into the topic, I do want to get clear about why we're highlighting needs. So needs are these fundamental requirements or problems that we need addressed in order to be successful. When we articulate needs, we create this shared understanding of what is called for, what's the gap, and we invite people into the problem solving with us. That is different than a strategy where we might be suggesting approaches or plans to address those needs. When we suggest strategies, it doesn't necessarily take into account someone else's perspective. So it's easier to shut down. So that's why we're deciding to focus on needs today. And with this, our goal is to look forward. So we really are saying let's get clear about what we see as happening in current state, what's working, what's not working, what's wanted and needed so that we can productively look forward, really trying to avoid blame and looking back. This is also an invitation to get on the balcony, as we like to say, and view things from a different perspective. Okay, so I'm going to invite you just to take a step back as you digest the rest of this talk. Okay, so business of medicine. How many people in this room got education in their training years about the business of medicine? 2 hands, maybe 3. So minority. And yet, this is something that is significantly impacting our lived experience every day. So what have we seen with the evolution of medicine? We have seen that more and more physicians are employed by these large health systems. Even just in the last 10 years, if you look at the percent that's employed, it has increased dramatically. What this means is that we have become increasingly disconnected from the business of medicine and what it takes to exist as a business in medicine. Furthermore, many of us took these jobs because we didn't want to have to think about the business of medicine. So over time, and as more and more of us have become employed, we can appreciate we are now living this increasing divide. So part of this phenomenon is that we haven't necessarily wanted to be a part of the business of medicine, and finances have not been a regular part of communication until it's been more dire over the recent years. Many of us gradually adopted the role of expecting our leaders to run the business for us, right? I need you as a leader to fix the problems, run the business, and give me what I want and need. Furthermore, because our organization is so large, it is necessitated that many of our leaders have to take on full-time roles leading and running the business, and they are no longer practicing clinically. And so as that phenomenon, you can imagine that as this grows over time, our leaders are in one world and our clinicians are in another. And when I look at how we're engaging around this tension right now, what I notice is that we are coming at problems from totally different vantage points. In fact, we're not even speaking the same language a lot of times. So I know that many of us are feeling these business decision impacts, benefits cuts, staffing changes, RVU expectations shifting. We are being asked to do more with less, or that feeling. Also imagine, just to give voice to a different perspective, you're in charge of a multi-million-dollar budget, and you have to figure out how to close a $20 million budget gap in the next 6 months. What might that be like? So I just want to name two that I think both sides on this divide are protecting ourselves by not engaging in the other. It's hard to look at that reality of a $20 million budget gap and say, gosh, oh my gosh, that's very unsettling for me. Or if you're making that decision, really looking at and sitting with what are the impacts on the people, the patients, our caregivers, our physicians. So as we're not speaking the same language, and because we're coming at things from such different perspectives, it's become increasingly easy for us to other each other. In other words, label and blame someone else for the problems. This has been amplified by communication being so challenging in the size of our organization, the complexity of our organization. And when that happens, both sides are filling in the gaps. So we are walking around with lots of stories. And I just want to give voice to my experience, particularly over the last couple of years. Scarcity has amplified and accelerated this erosion of trust. Okay, a quick note about how are we defining success? Are we defining success by have we balanced the budget? How many patients are you seeing, or RVUs are you generating? What are our quality metrics? What about how much did you connect with the last patient that you saw? How much or when's the last time that you paused to have a hard conversation with a colleague about accountability, culture? One aspect of this business of medicine is actually looking at our organizations and how we are defining clinical excellence. So imagine that you are rounding on 15 patients in the hospital, and guidelines and best practices that you are having shared decision-making with every patient every day. Are you discussing every test you're ordering, every result that you get? Are you discussing the patient goals every single day? Is that possible? In the clinic setting, right? Every single patient must have a PHQ-2 done every single visit, even if they were seen the day before. We must offer a flu shot to every single patient. Again, alone, none of these are a problem. But there was the study a couple of years ago that looked at, well, gosh, what are we talking about here? And they estimated that to provide guideline-based adult primary care for a panel of 2,500 patients, it would take 26.7 hours per day. Obviously, there are not that many hours per day. And this has been kind of this idea of tasks or expectations has risen really in some of the national dialogue. There was a plenary session at the National Physician Wellness Meeting just a couple of months ago talking about this idea of administrative harms. Now, we find that the words administrative harms to be provoking and othering. So we've decided to relabel that as task burden. But the reality is that success is being defined both outside of our organization and inside of our organization. And a lot of this has been determined by the business of medicine. Some of it's essential. We get financial reimbursement. We're graded on how we do in some of these tasks. Furthermore, our brains like clear objective information, right? So like it's easy to track how many RVUs did I generate. It's harder to track how much did I connect with the patient that I just saw. So I just want to give a quick note to this phenomenon, like what are the consequences of living through this time of high task burden? Well, there's a lot of personal impacts here. So if we think about, what it really takes to do the job, and you show up, say you're a hospitalist, you have 30 unread emails because you haven't been on service, you've got 5 Epic chats, 2 Teams chats, 3 patients that need to be discharged before 10 and an unstable transfer from overnight. And then your leader asks why you haven't done your health stream modules for the last 6 months. Right? I say that with some joking, and that could happen, right? So giving voice to this, of course, we, are feeling this one more thing. And why might we see these big reactions to that one more thing? Well, it's because the burden that we're all facing every day is so big. Part of what we do as a coping strategy is that we are building walls or putting up boundaries to disconnect from our teams, from our leaders, and from our patients. And we're doing this because we have so many tasks that we have to get done throughout the day for survival. And yet, when I look at, oh my gosh, where are we losing community and meaning in what we're doing? There's a big cost to that. Just to give voice to another perspective, imagine that you are held accountable for quality metrics for your hospital. With that, reimbursement, how your hospital is graded, not only that, how your patients are doing, and your job is requiring that these metrics are met. What might that be like? I see huge impacts on teams around this prioritizing metrics. So if you look at how we are spending our time together as clinicians, in my experience, a lot of our meeting time is focused on operations and metrics. With this, we are losing team trust, connection, and culture building, and we're deprioritizing not because we don't care. Of course we care, but it's out of necessity of how are we actually going to get through the tasks that we need to get through. But this loss of our teams and our team culture and empowerment is significantly impacting our everyday experience and how we feel at the end of the day. All right, last kind of impact I want to name is this organizational impact. At the national meeting, there was this wonderful presentation. They looked at ED physicians, one group, and they looked at best practice alerts that would pop up in Epic. They assumed that there was 90 seconds of task switching time, which is pretty broadly acknowledged and accepted. And then they looked at what's the time cost of those best practice alerts. There was an average of 9 FTE per month for ignored alerts. This is just best practice alerts in one ED group in Epic. Furthermore, if we think there are so many priorities, there's so much happening. And so what happens is there's no priorities, right? This is the quiet quitting. This is the disengagement out of necessity. So it also, from an organizational standpoint, it makes it way harder to implement change because we are disengaging as a coping strategy. Again, none of this is the intent. It's not any one of these metrics or tasks is problematic, but it's looking at the big picture. So to look at needs, first, name the impact of the decisions you see with curiosity. Can we all be open to looking at what someone else might be seeing and create more of a shared understanding? Can we create bidirectional transparency? Can we effectively communicate what it is that we want and need and understand the same? Critical evaluation of tasks and alerts, and really awareness of time and how we're prioritizing it. So an invitation to look at this big picture. And with that, I will hand it over to Alice.
Okay, so I'm going to talk about a couple of things, autonomy and our culture, and I'll start with autonomy. We hear this a lot from clinicians that autonomy and we don't have enough autonomy to get the things done that we need to do so that we can do our job. So it's like this picture, right? You have so many tasks and decisions and policies that are kind of strapping you back and not letting you get your job done. And I want to level set because a lot of times we get confused in medicine that autonomy and independence are the same, but they're not. Independence is not being reliant on anyone, being able to thrive on your own. That is not what we're talking about here. We are talking about autonomy, which is the ability to make decisions and take actions without external control, freedom to govern yourself and your team, and to ask for what you need. So again, autonomy, freedom to govern self and your team. I think, where do we have autonomy and who is our team? I think that's a big question, right? Who is our team? Is it you and the patient? If that's the case, then you have autonomy to make some clinical decisions. You also have limitations though, with insurance demands, et cetera. If your team is your clinic or your broader clinic, there's a lot of different stakeholders and competing demands in your clinic. But you might be more flexible to make change in that small level. If your team is Oregon, Providence, that is a lot of different stakeholders and competing demands. And if a decision is made there, that might impact the autonomy at the lower level. If your team is Providence in 7 states and a decision is made there, then that might impact your autonomy at all of the lower levels below that. So just thinking of that, and I like this picture because this little guy is free. He can get out of the cage, he can do his job, get stuff done. So what we're really talking about is decisions and clarity with decisions. So we make multiple decisions every day and really stressing that we're interdependent. So, as a clinician, we're interdependent on our operations colleagues, and we don't know as much about the financial decisions. In addition, if you're making financial decisions or operations decisions, you need buy-in from your clinical team to really have those happen. So again, interdependency is what we're about at this point. So really clarity. Is there a decision to be made? There's a lot of things that there's no decision, right? It's out of our control, sometimes like governmental regulations or what have you. But there are some sub decisions that are under that, like who does what. Those are decisions that can be made. So being very specific about what decisions we're talking about, and then even more clarity about who will be making decisions. We see a lot of confusion about that in the clinician experience team. People feed that back to us. Who made this decision? I thought I had input, but I didn't. So clarity about decisions will help collaboration, transparency, and to build trust amongst all of our team. I love this graph because it's really simple, right? This is a graph that shows that decision-making rights, like being really clear who's going to make the decision. We have time on the x-axis and buy-in on the y. And you can see, I mean, it makes total sense, right? It's kind of, the linear. If you have more time and you communicate with more people and you get more collaboration, that's going to take more time, but get more buy-in. And just to state that in an organization that's so complex as ours, and you have multiple layers of leadership, you will have to get clinician buy-in, you will have much buy-in easier with less time if the decision is made closer to where the clinical work is happening. So closer to the ground. If you're making a decision really far away from that, you're going to need more time for buy-in. So if you look at this graph, it's pretty straightforward. The most efficient in terms of time is leader decides. Leader makes the decision, it's done, but there will be less buy-in, of course. Leader decides with input. You will have more people involved, so there might be more buy-in depending on who the leader is, depending on who they're getting input from, and depending how close to the actual impact it is. Subgroup decides, will get more buy-in, take more time because there's more people, and you might get more buy-in depending on who the subgroup is. So do we trust the subgroup? Who was chosen? Who's on the group? Do we know them? Do we trust them? But again, a subgroup that's well chosen, especially if it's close to where the decision is going to have most impact, huge amount of buy-in. Majority vote, lots of buy-in, but takes a lot of time. And consensus is super rare. That's like where everyone agrees. Yeah, how often do we do that? That's really, really difficult, but lots of buy-in. So this is really helpful to make sure that you're being transparent with who is making the decision so that people aren't confused and they kind of know what's going on and is transparent. So that what we see as needs here is we really need more collaboration to get adequate buy-in, to get people all on the same team and on board. We also need clarity about decision-making rights because we really want to avoid people thinking that they have a vote when they just have a voice. And we also want to avoid people thinking they have a vote or a voice when they don't at all. So in a leader decide situation, we don't want to have that confusion. We need transparent communication without spin. So we really want to know where we're standing. And if you look at all of this decision and buy-in and collaboration, autonomy at the local level will be pretty efficient because you'll be able to get buy-in easier. The decisions are being made at the ground. You will improve team dynamics and be a little more flexible to meet competing local stressors. Because what like I need at St. V's in my clinic in primary care is real different than what Gateway might need over on the east side. So I think this is where we're kind of coming to that would help us all work together and continue to have autonomy. I'm going to switch gears a little bit and talk about medical culture. And this is a fascinating topic for me. I mean, I'm old. I've been in this job a long time. I've seen medical culture evolve quite a bit. I really love my job and my colleagues, and medical culture has some amazing values: hard work, compassion, kindness, love of learning. I think this is all awesome. I'm going to use our time today, though, to talk about some of the harder things. So this does cause me a little distress to bring it up, but I think it's something that needs to be named. We really are seeing a lot of evolving stressors in medicine without really time for collaboration, and that is causing misaligned expectations. So culture definition, unspoken rules and expectations in a group. Because it's unspoken, it's super difficult to see because it's our default behavior. So it's just like how we exist in the space. With awareness, we can help understand kind of where we're at and understand each other. And the big thing is culture is not static, so it changes. So this is such an opportunity for us to really look at our culture, to determine what we want to keep, what we want to change, because there's a ton of opportunity here without a lot of cost, except for awareness. So here we go. So there's a lot of stressors impacting healthcare culture, and y'all know this. Aging population, increasing medical complexity. What this means is that we're having increasing, public payer representation with Medicare, and so decreased reimbursement, increased workload, clinician shortage, y'all know this stuff, increased specialization out of necessity too, because things are more complex. Our teams are really large. You have some patients who maybe have 5 specialists, but there's no time for collaboration, which makes it really, really difficult to work together. We have increased employment by hospital systems, as Tricia talked about. So clinicians are increasingly separated from financial understanding, and administration or operations is increasingly separated from clinical work. We have this, with all of these financial stressors, we are seeing and hearing about a lot of protectionism of individual groups rather than teamwork, which creates a lot of us versus them mentality. And that is, we can impact that. So a couple of things that we're going to talk about today is we see these generational differences. We have 3 generations in medicine now. Culture has changed a lot over that time. So we kind of defined it as old school and new school because it doesn't necessarily correlate with your age. I have some younger colleagues who practice more like old school and some older colleagues who practice more like new school, but there's some differences in job definition. So, old school tends to think of the job as a calling or identity. New school tends to prefer shift work. Autonomy preferences are different. So old school tends to prefer individual autonomy, and new school tends to prefer team and teamwork autonomy. boundaries and priorities are different. So there's so many competing demands, as Trisha was naming, that we are setting boundaries. Old school tends to set boundaries with protocols. So, in alignment with, Claudia laughs, with in alignment with that, like, individual autonomy. If a protocol doesn't make sense to old school, they just say, I'm not going to do it. New school tends to set boundaries in alignment with work-life integration. So trying to protect from overworking. So there's pluses and minuses to both. Neither are bad, and there's no problem, but we definitely can learn from each other. And it's good to have awareness because we're working together every day. And here's a big one, hierarchy in medicine, you guys. Can you really see it? You want to look at it? Yeah, it's hard, right? I mean, hierarchy in medicine has been long-standing. It's super obvious when we're all in training. We even have it in what we wear. Short coat means one thing. Long white coat means something else. What color scrubs you're wearing. Where, all of these things are all signals, and these are cultural signals. We see it in roles and titles, MD, APP, RN, MA, and that's all different levels of hierarchy. We see it in specialty with, procedural specialties prioritized in the hierarchy. We see it inpatient, outpatient, academic, not academic, leadership, not leadership. Even with clinicians, patients, right? The hierarchy is all the way through. I think the struggle here is that we all, in our medical culture, often prioritize workload over appreciation and belonging. And we know from looking at so much literature about burnout that belonging is imperative. So if we don't take the time to appreciate each other and create a sense of belonging for all, it's a really lost opportunity. In addition, we don't have time for collaboration. So across all of these cultural issues, we don't make time to collaborate with each other, which is missed opportunity. And we clearly need leadership opportunities for everyone in the hierarchy. So just a pause for reflection on how does the hierarchy impact how we're showing up, how we communicate with each other, how we're collaborating with each other. Are we defining roles or are we just making assumptions? Are we appreciating each other and creating a sense of belonging for all? And I think there's a ton of opportunity here. And this leads us to, this is the solution, right? Practice of perspective taking. I like this little cartoon because here's these two folks, they're looking at a number. Is it a 9? Is it a 6? It could be either, depending on the way you're looking at it. And this is really a place that, and this is free. I know we have a lot of financial distress, but we can all do this. We do it with patients all the time. So the ability to consider and understand how others see, think, feel about a situation, even if you don't share the same experience, it requires a lot of curiosity and flexibility because your perspective might not be right. And it's difficult to do if you're really reactive because it really takes, you need to step outside of your own viewpoint in order to make space for someone else's experience. But we do this in our clinical work, so we can definitely do it for each other. So we see the needs as this, intentionality about culture. Again, there's so much opportunity to impact some of these things we maybe don't want to keep. We can learn from each other. So if we look at all these subcultures in medicine, some do meaning at work better, some do boundaries better, some do teamwork. We can really use this opportunity to create a stronger group. We need to practice perspective taking to even be able to get there. Respect and appreciation are super important. And we know, again, that the sense of belonging is very protective against burnout, and we need leadership opportunities for all. So with that, I'm going to turn it over to my amazing colleague, Karina.
Well, good morning. As I was driving in this morning, I heard a song on the radio and it was talking about planting seeds in order to be able to have the garden that you want. And so I think a lot of what we're going to talk about here is really trying to plant the seeds for how we go ahead and move forward together. So I'm going to try and lay out a blueprint for you guys. And this blueprint is based much in the experience of my team, but also in the evidence that is available around clinician well-being. So after this discussion, you might be feeling like this kiddo, and I see that he's probably a little sad, maybe a little helpless. You might feel discouraged. And if you're feeling that way, I can say with confidence that you're not alone in that. Our system truly does feel like it's buckling, and I don't know about you, but it does make me wonder, is this really what I signed up for? So still, we're all here, and I hope that we're all going to stay in this system together. In the next few slides, I'm going to lay out that blueprint, and it's going to be 5 opportunities for clinicians and 5 asks of our leadership. And if you're really just looking for the cliff notes, it's already been alluded to, but the power of this change really lies in us. So the preamble to the journey that we're going to take together is to really acknowledge that we're all human. And in this humanness, we're messy, we're imperfect. We oftentimes feel like imposters. We might be morally distressed, and some of us may even carry trauma from the work that we do. Yet it is in our humanity that I see that we have potential, and that's through creating this community and allowing the power of us to come together. So first, we're going to look at the opportunities for us clinicians. Opportunity 1 is refinding the reason that you entered into this healing profession. Finding purpose and meaning is not a new concept to weather tough times, and I think most of us probably counsel on this regularly, either in the exam room or maybe when we see a patient in the hospital. But when was the last time that you actually allowed yourself to stop and consider this? What are you doing here, and why do you do this work? I would argue that many of us did not go into this profession and do many years of training, some more than others, simply for the money. I would also suggest that we probably don't expose ourselves to others suffering day after day simply for the paycheck. And it makes me wonder if we show up for something that's deeper and something that keeps us all wanting to come back every day. So could you allow yourself to get curious? Curious about yourself, curious about your colleagues, and maybe even your mentors and why they do this work? Could you allow yourself to imagine for a moment that you're regrounded? So regrounded in the purpose of why you're here. Could that potentially inspire the people around you? And with that, could we start to heal each other? I dream of a day when we as clinicians could start a new epidemic, an epidemic of clinician healing. So now I'm going to give you the invitation to unlearn. So we all hold many beliefs that come to us from our training, from our experience, as well as from our culture. And I would like to give you permission to unlearn that which you know and which is no longer serving you. So this might be something like, I have to be perfect. I need a certain amount of time with my patients for them to get good care. I cannot rest. I cannot be vulnerable. Or maybe it's simply something like knowing your colleagues on a personal level is unprofessional. So by giving yourself permission to change, to be flexible, and to be a bit more human, you also give that permission to the people around you, and they may need it. The third opportunity is the opportunity for co-creation and using the power of co-creation. So as clinicians, we're naturally solution finders. We have patients come into our exam room, we create a list of differentials, and then we come up with solutions. But what if you didn't have to hold all of that responsibility yourself? What if you could co-create with the people that are around you so that you could build on the knowledge and skills that they have and possibly create something that's different and better and something that everyone feels like they have ownership in? So we, the clinician experience team, we do believe that we are very skilled problem solvers, and we believe that we hold the solution to many of our local problems. We simply need the opportunity as well as the permission to navigate disruptively together to create something different and maybe something that's better. And by using this power of co-creation, we can keep evolving ourselves and keep ourselves grounded. I encourage you to not assume what is getting in the way of your colleagues. Let's take the time to ask them, let's state our needs, and let's go ahead and collaborate here. And I imagine you might not get it right the first time. And if that's the case, we're human, just try again. So one successful example of co-creation that we're really proud of is the Clinician Wellbeing Consortium. And that first slide one of the first slides that Tricia referenced with all of the graphs was from this program. So it's a 15-month wellbeing leadership program, and it's really based on co-creation. So the first cohort was 21 individuals, which are pictured here, and it happened from 2023 to 2024. And in that group, there was an astounding drop in burnout rate for those participants. It dropped 34% and landed at a mere 13% burnout rate, which I think is pretty wonderful. And we are currently in our second cohort of the Clinician Wellbeing Consortium, and that will run 2025 and 2026. And that group is pretty exciting. It's clinicians as well as clinician leaders. And so it'll be interesting to see the possibility that comes from that group. So building on co-creation is the idea of building collective wisdom. We each have something to give as well as something to receive. And through curiosity for one another, we can build this collective wisdom. But it is going to require a mind shift for many of us, a mind shift from me to the team, and oftentimes from them, allowing them into the team. So it really seems a little bit silly to describe how siloed we are, but I do think that it bears highlighting because that knowledge sharing is not a built-in concept and it's not easy anymore. In this way, we sometimes forget to look around us and appreciate the breadth and the depth of diverse knowledge that we have. Knowledge that comes from years of experience, different types of experience, as well as our interests and our training. So I wonder what it would be like to listen to our colleagues with curiosity. Can we find the other perspective? Is there room for yes and communication? Yes, I hear what you're saying, and I wonder what this approach might be like. We believe that collective wisdom is going to be what allows us to avoid the missteps that we've made in the past, while also incorporating novel strategies that are going to take us to the next level and allow us to be current. So let's learn from each other. Let's assume the best intent in what might seem out of the box from our typical way of doing things. And let's be grateful for our different trainings and our generational attributes. Let's consider other perspectives, and let's try to reduce the othering that is really happening. Othering that Alice described between generations, old school versus new school, that's really happening with APPs and physicians, and that's really happening between our leadership and us. So the fifth is unlocking the power of your team. In this final opportunity, I'm going to try to put it all together for you. So by recognizing and accepting that we're humans, we give permission to those around us to do the same thing. By refinding your why, it can remind others that it's okay to ground yourself. By considering different perspectives, you create community. And in co-creation, you have the opportunity to build something that's better. And then through collective wisdom, you can create belonging as well as safety. Come on in. All of these things then set the foundation for establishing trust, and trust is essential, and it is required for us to build a path forward. But trust takes energy as well as intention and vulnerability to build. But once it's established, the power of a team can really flourish. And we think, and we truly believe, that one of the keys to us thriving together is building effective and trusting teams. So I've given all of us quite a bit to think about with these 5 opportunities, and I'm not going to assume how they may have landed with you. But I do want to offer up that we, the Clinicians Experience team, we're here specifically to help raise your voice and also provide support. We have simple things like group coaching as well as team resets. And if you need any support, we're here for you.
So now I'm going to shift and I'm going to talk about how we can build a bridge with our leadership. But before I do that, I think Trisha alluded to this a little bit as well. I really want to thank our leaders. They keep showing up day after day. We think it's hard, and I would suggest it might be really hard for them as well. So also, in an effort to build a little bit of collective wisdom and share a little bit of my humanity, I'm going to share 2 missteps that I've made this year. So hopefully you won't have to make them. The first one is the belief that that which seems under our leadership's control may really just be in their level of influence or concern, essentially saying that our leaders don't always have the decision rights that we think that they do. And so we need to look at that possibility. The second one, which really was not intuitive to me, is that psychological safety often decreases as individuals get into higher levels of leadership. So if we acknowledge this, it allows us to show up with our leaders differently and potentially engage together differently. So now the needs and the support opportunities for our leaders. Leaders, please, before you do anything else, remove the things that are getting in our way of showing up, those hindrance demands. So these are things like unnecessary screening, loss of autonomy, building policies and procedures that maybe check a box, but don't serve the greater good. And I would say sometimes metrics feel like they fall in here too. While standardization has its place, it's counter to the autonomy that teams need to build trust and also a way of being that works for them. Give us guardrails, please, but allow us autonomy and creativity in between. Partner with us in making change, but be curious about what the front lines really are like right now. And then we as clinicians by nature, we're leaders on our team, but leadership truly is a skill set. So as Alice said, please offer more leadership development opportunities for both APPs and physicians. And through doing this, I think that we will be able to help you with the change management that's needed. Please allow us time to build relationships. And through this time, we can share wisdom and we can support each other. And that's going to allow us as clinicians to adapt to the rapid changes a little bit easier. So we, the clinician experience team, on most days, we really do believe that it's possible to build something better. And this is a picture that Alice took during the pandemic and when times were really hard. And I will also remind you that the 3 of us, we're genuinely smack dab in the middle of all of this with you. We feel the same pressure and possibly some of the same pains, same pains that you might feel on a day-to-day basis. And I also think that it's okay to disclose that not every day we're okay. But still with that, we do think that there's a path forward and we think that there is a way through this. And we believe that it comes in unlocking the power that we have with what is under our control, as well as that which is under our team's control. And through doing that, we do think that we can build something different and something hopefully better. So let's just do it. Let's get grounded in caring for our patients. Let's assume the best intent in each other. And then let's simply be better together. Thank you.
Thanks so much. Probably lots of thoughts percolating. I'll open it up to the room for any questions.
Oh, thank you very much. As a recently retired private practitioner for the past 40 years, I asked the question about malaligned incentives because when I look at the picture that we paint of medicine in 2025, I see malaligned incentives for the insurers, the politicians as being in conflict with what we as internists try to do, which is diagnosis and management of complex disease.
Yes. I think, just kind of naming and bringing to awareness, I agree with you. That's my kind of calculation or perception of current state. And when I think about how do we approach this current time, clinicians have a lot of potential and influence and power and deciding and being a critical part of co-creating what comes from here. Now, I don't have an exact path of the way that looks, and I believe and want all of us in this room and all of us online to be a part of that creation of what has to change and what comes next. And so it is getting clear for each of us as individuals, each of us as teams, what does it look like? What do we have control over? And how do we maximize our influence to affect change? But we have to start where we have control first.
Thank you to all three of you. I have so many things percolating that it's amazing. But this malaligned incentives, because on my worst cynical days, I feel like we're this lovely nonprofit system that I am now, as of Saturday, 30 years here. Woohoo. That due to financial pressures, we're outsourcing to for-profit businesses. And then on my better days, I want to think, those for-profit businesses, they don't get up every day saying, I want to screw patients. I mean, I just can't imagine that they do. So finding where those win-wins are and saying, even though it makes those of us who didn't go into business kind of a little queasy, just thinking about profit, profit in itself is not evil. It's when profit takes priority over our patients. And so I think that that's where our voice, hopefully can be powerful. And then I just have one comment for Alice. 30 years ago, when I had to do some leadership training, I was taught that consensus is not that everyone agrees. It's that there has been enough transparency and understanding that everybody can live with the decision. And I think that that's an important distinction, because I think we should still be working and demanding for some consensus. Thanks.
Good call.
Thanks for your perspective. One of the things I'm so struck by in the way that you're talking versus I think a lot of the rhetoric and group talk that I hear on a regular basis is that you have a profound sense of understanding and empathy for the people up top who are making very difficult decisions that I think has been incredibly difficult for those of us on the front lines to cultivate in the same way. In part, I feel driven by a sense of separation of those making the decisions and those doing the work. How do you think that we as an organization can get on the same page so that we can maybe turn the tide of those doing the work feeling like those up top aren't listening, don't care about us, don't see us, don't hear us, are out of touch?
I think part of it is knowing each other. So knowing each other, having time for collaboration and transparency. I think sometimes we're speaking different languages and we don't take the time to clarify that. I think that's one piece, and perspective taking is really the way forward, in that I don't think anyone in this organization is here to not move health forward, really. So if we did it, perspective taking is beyond even assuming best intent. It's really trying to see the other perspective. And I think we're all so busy that we don't take time to do that. So it probably starts with all of us, including everyone who's doing operations and leadership.
Yeah, two quick comments. One is it's a lot easier and it feels a lot better in the short term to blame an other. There's a reason we're all doing it. Human and not very productive. So the first is just like some self-compassion. Yep, ended up there. I end up there all the time. And when, right, recognizing we all have an opportunity to take a step back, get regrounded. What do I need to do? What's in my control? What else might be possible? And then I really believe in the power of conversation. So like the more that I have gotten to know our Oregon executive leaders, it has been profoundly helpful for me in that perspective taking and understanding of like, oh, there's this whole thing I wasn't even seeing or perspectives I wasn't open to. And actually, you're an amazing person and leader. Like, so, but that's been possible through conversation. And so how do we create more opportunity to have conversation together, which is really going to help both sides with that perspective taking.
Great. Well, with that, I'll acknowledge that we're at 9 o'clock. Thanks to the three of you for this very important work.